Hi everyone, my name is Abigail, and today our group will be presenting on the impacts of sexually transmitted infections on maternal health and how they affect the course of pregnancy, specifically focusing on risky behaviors that lead to developing an STI.
Okay, so first we have some background information. So the CDC reports that the number of annual STI cases in the US have been increasing for 6 years and are currently at an all-time high. And then regarding secondary prevention, not all doctors perform STD tests regularly and thoroughly during pregnancy. And regarding tertiary prevention, antibacterial meds are generally safe during pregnancy, and antiviral meds can reduce chances of transmission during birth. And then risk behaviors for maternal STIs. So first, the time and number. So early sexual activity, especially before the age of 18, in multiple sexual partners are considered risky sexual behaviors. And then during intercourse, lack of or improper condom use, alcohol or drug use, or exchange of sex for drugs or money. And then reasons for these risk behaviors, there is an underemphasis on male behavior. And there's also a lack of awareness on STI symptoms, prevention, and treatment, a lack of access to affordable medical care, and the stigma and shame that is associated with STIs. Okay, next we have the most common maternal STIs from 2016 to 2018. So as you can see on the left, we have the rate of chlamydia in the United States for maternal infections. You can see that it has been increasing for the past 5 years. And then again, with gonorrhea and syphilis, the incidence rate of those for maternal STIs has also been increasing. Other common maternal STIs are HIV and hepatitis B, but the rates of those are significantly lower since they are more tested for during pregnancy and easier to treat. And then adverse outcomes, maternal STIs that are untreated or not treated timely enough will have an impact on the mother and fetus. And so some of the adverse outcomes listed on the neonate are congenital syphilis, eye, lung, or liver infections at birth, premature birth, low birth weight, infant death, and chronic diseases. And then adverse outcomes on the mother are ectopic pregnancy, maternal sepsis, premature labor, premature rupture of membrane, miscarriage, stillbirth, the emotional psychosocial effects, and vertical transmission of the STI to the fetus during pregnancy.
And then now in terms of disparity, age and educational attainment coincide, where on the left, younger ages are seen to have higher rates of maternal STIs, where at ages such as 15, and then they peak at ages 20 to 24 years old, where risky behaviors are more prevalent. And this also might be correlated to just lack of sexual education, whether that's in school or outside resource centers, where they learn things such as condom use. It's also important to note that in this graph on the left, there is an increasing rate of syphilis with 40 and over, but it's still not as large in the age 15 and 24 group. On the left, we have educational attainment, and it was found that mothers with higher educational attainment, such as a bachelor's or master's degree, might have lower rates of gonorrhea during pregnancy when compared to those who had less than a high school diploma or completed their GED, with rates being almost 5 times higher for the latter group. In our next slide, we also have disparities with regards to race and gender. So with race, there were much higher instances of non-Hispanic Black, along with Hispanic people who had higher rates of chlamydia in pregnant women. This might be attributed to larger issues within the US, such as racial segregation in neighborhoods, as well as income inequalities, both of which increase STI rates on their own without regard to race or pregnancy. But since there is a higher racial segregation and lower incomes in neighborhoods with Black and brown folks, it is representative of an overall health disparity among these racial groups. Similarly, when researching transgender experience, there was an underwhelming amount of data, but Fenway Health, in collaboration with Harvard Medical School and the National Health LGBT Education, studied reproductive health care and transgender patients, and I have included some of the most commonly stated experience, where the feeling of isolation along with degrees of gender dysphoria, both of which patients said deterred them and caused negative experiences, specifically when their health care team didn't use proper pronouns or denied them services.
The CDC guidelines for screening do reflect STI trends. However, adherence to these guidelines is low, particularly among people who do not have insurance. Most of the groups, as you can see on the slide, that are recommended for repeat testing are high-risk groups, but they are least likely to attend prenatal visits where this screening occurs. Additionally, STI screening is a financial burden, and it doesn't address the root cause of high-risk status in any meaningful way. So some factors that prevent successful interventions are repeat testing being expensive, doubly so if men need to be tested as well. Both partners in the relationship are responsible for the health of the infant, and recommending screening for male partners may help with the issue of STIs. However, it would cost more. Individuals at risk groups are also less likely to have insurance. Again, many women also do not have access to prenatal care, which is where these screening resources are provided. And preventative screening for STIs as a general practice, even when not pregnant, is also cost prohibitive for individuals in at-risk groups.
So in conclusion, rates of maternal STIs are impacted by various disparities, including but not limited to age, education, race, and gender. And in order to prevent these rates, we can encourage increasing access to educational resources and the involvement of male partners to avoid damaging health effects on mother and child.